We are privileged to have Dr. Ann Zaia as tonight's speaker. Ann is a board-certified occupational health nurse practitioner and healthcare executive with more than 30 years of experience across academia, hospitals, biotech, and biopharmaceutical settings. She is a recognized leader in occupational health, clinic management, biosafety, and bloodborne pathogen exposure management, including work related to BSL-3/4 laboratory safety and exposures. Her expertise includes OSHA, FAA, and FMCSA regulatory compliance, as well as incident command, hospital preparedness, practice management, and healthcare information systems. Ann will be presenting on post-exposure management of bloodborne pathogens. Dr. Zaia, the floor is yours.
Thank you so much, Kevin. Thank you, everybody, for coming. This is, as Kevin was mentioning earlier, a very important topic, very near and dear to my heart for many, many years, and a great interest of mine, as Kevin was mentioning earlier. And to any of you that have ever had an exposure, known anybody that's had an exposure, you can certainly understand the importance and potential brevity of being exposed in an occupational health setting. So we've come a long way. Kevin was mentioning that when he had needle sticks, he didn't get a particularly promising response from his particular healthcare setting regarding needle safety. And we've come a very long way with needle safety, especially with the 2001 Needle Safety Act that was promulgated as part of OSHA. So the key things that I'm going to talk about tonight for post-exposure management of bloodborne pathogens are rapid triage, practical post-exposure prophylaxis, which, by the way, many of you may be aware was updated with the SHE guidelines in fall of 2025. That was the first time in quite a long time, and we are thrilled about that, as well as clear counseling. Counseling is a very, very critical part of bloodborne pathogen exposures. In fact, in my mind, it's as critical as post-exposure prophylaxis. Okay, so what are we talking about? What counts as a bloodborne pathogen exposure? And in order to have a bloodborne pathogens exposure, we have to have some type of fluid, potentially infectious material. We have to have a portal of entry into the body, and that's what equals an exposure. Not every exposure that we see is a true bloodborne pathogens exposure. It's up to the treating provider to ascertain by taking a really great history as quickly as possible, because as y'all know, time does matter in this situation. But it's very, very important to take a clear history. When people have exposures or think they have exposures, it's probably one of the most stressful situations they'll have in their clinical lifetime. And sometimes facts could get confused. By nature, humans aren't great at recall. And it's very, very important to make sure that you get the facts straight, you get them clear, and you help to calm the patient when they're telling you their story so that you can make the best decision in terms of risk management. So things that we do consider potentially infectious, obviously blood, visibly bloody fluids, semen, vaginal fluids, selected sterile body fluids such as spinal fluid. People will often come to the clinic and say they've had an exposure because they were splashed from urine from a catheter, screening a patient, were splashed with feces, or somebody vomited on them in the emergency department. These are not necessarily bloodborne pathogens exposures, and typically they are not. In order for saliva, sweat, tears, urine, feces, vomit to be considered a bloodborne pathogen, they must have visible blood. So not microscopic hematuria. I've had people come and say, oh, I looked up their labs, they have microscopic hematuria. It has to be visible blood in these particular specimens in order to be considered a bloodborne pathogen. If either of these elements are missing, the fluid, the OPIM, the other potentially infectious material, or the portal of entry, then it isn't an exposure. What do you all think about human bites? We often get patients to come in with bites, especially we see people from other entities police, firefighters, EMTs, and they get into a tussle with a patient, even people that work in the hospital. There's a lot of, Chris will tell you, there's a lot of violence in the hospitals these days, unfortunately. People will get bitten. Is a bite, a human bite, considered bloodborne pathogens exposure? What are your thoughts?
Well, probably not from what you've outlined.
Right. And it depends, Kevin. You're absolutely right. The majority of the time it's not. Now, it doesn't mean we're not going to treat it, because as we all know, the human mouth is very bacteria-ridden and likely need antibiotics for the bite if it broke the skin. So first of all, you have to see if the skin is intact. The skin's intact, it's not an exposure at all. If the skin is not intact, then the next question you ask is, was there visible blood in the mouth? And HIV, Hep C, and Hep B are not easily transmitted because of the enzymes in the mouth. And typically, bites are not considered bloodborne pathogens exposures. But again, you have to ask the right questions to know. Okay, so what do we do in the very first 15 minutes? Hopefully, the person's reported very quickly. We do often see people late reporting. I had situations where people had a needle stick in the OR on a Friday night. It was late. Occupational health was closed. They didn't know there was an after hours number. They said, oh, I'll just report on Monday. And then it was too late. So hopefully they've reported quickly and they've done all the right things before they even come to see you. The first thing we want to make sure they've done, and if they haven't, we're going to do it, is to wash with soap and water. If it's a mucous membrane, eyes, nose, mouth, we want them to irrigate those areas. If they're irrigating the mouth, swish and spit, do not swallow. And very important, and this is something people often forget, if they have contacts in, and please ask, because people don't think to tell you, if they have contacts in and they've had an eye splash, they must remove the contacts and they must be disposed of. We can't have them re-sterilizing them. I often see people come in and say, oh, I cleansed the wound, I put a whole bottle of betadine, I put a whole bottle of hydrogen peroxide. And I've had people say they've put bleach on it. People get very, very anxious when these things happen. People squeeze their fingers until they turn purple. These are all things that should not be done. Any of these agents could be tissue toxic. Soap and water is absolutely the right answer. Please do not have them squeeze or bleed the wound. Actually, with the capillary action, when you release it, it will actually draw more fluid into the vasculature. I tell people this is not a snake bite. We also want to make sure, we want to ask them if they've reported it to their supervisor, occupational health, employee health pathway. And what I always tell people when I'm going out and talking to different departments is reporting is important, but please do not delay care. I've had people that say, well, I couldn't find my supervisor, so I didn't come. Do not delay care if you cannot find somebody to report it to. Get care, and then we'll worry about the reporting later. If the source is available, please ask them, would you mind staying? We would like to test your blood. And it's fine if the patient asks them. And in my experience, 99% of the time, the patient is very helpful and they want to help the person. They feel very badly that this individual was stuck with a needle or splashed with their blood, and they want to be of help and get the situation straightened out and relieve the healthcare workers' anxiety. And remember, we have to arrange consent and expedited testing. So in your health system, make sure you understand how the testing gets done, because it does have to be expedited, because it does make a difference for the employee. The other thing to remember that's really important is that the PEP clock is running from the second that the person had the exposure in terms of HIV. HIV PEP cannot be given after 72 hours. There's just no evidence that it works after 72 hours. I've only once in my entire career ever prescribed it after 72 hours, and that was with an ID consult, with a known HIV positive patient with a very high viral load. Now, the 2-hour window, we tell people they must come within 2 hours because it has to get the medication within a 2-hour window. Where does that come from? There were studies, not on humans, they were animal studies. And those animal studies showed us that in most cases, the HIV virus attaches to the cell within 2 hours. Now, we use that as a standard. as the least common denominator, but we don't know in humans if this is the case, because it will, of course, be ethical to test on humans. But we also don't know if I'm a 2-hour person and Kevin's a 10-hour person or Susan's a 3-hour person. So we default to the lowest time frame that we know would be safest for everybody. So we do advise people when we're talking, again, when we go talking to departments, when we're counseling our employees, that we want to make sure you get care immediately, because we have to do the intake, we have to do the risk assessment, we have to do the prescribing, they have to get the medication if you're not keeping it in-house. And this all must be done within 2 hours, because the first dose should be taken within 2 hours. Okay, so what are we talking about in terms of bloodborne pathogens? We're obviously talking about Hep B, HIV, and hepatitis C. And Kevin was mentioning public health earlier, near and dear to my heart. My public health announcement is hepatitis B is far, far easier to contract than either HIV or hepatitis C. You can see the statistics here. And we have a wonderful vaccine. Again, Kevin was talking about vaccines earlier. I am very pro-vaccine, and this is one of my favorite vaccines. It is highly efficacious. It has very few side effects. There's very few people who can't get it. I often say to my patients, can you drink a beer and have a pizza while you're watching a football game? And, well, of course. Good, then you can get the hepatitis B vaccine, because the primary reason you can't, aside from if you've ever had Guillain-Barré, is if you're allergic to yeast, because it's propagating yeast. So it's a great vaccine. It's very effective. And it's actually an anti-cancer vaccine, as you all may know, because you can't get primary liver cancer unless you've had hepatitis B. So if you don't get hepatitis B, you're not going to get primary liver cancer, right? So hepatitis B and hepatitis B vaccine are exquisitely important. And we're going to talk about it a little bit later about getting your employees up to date on it. And it's the easiest one to catch. You only need the amount of blood from a hepatitis B positive patient that's on the head of a common pin to contract hepatitis B. HIV and hepatitis C, you need a much larger amount. So please, we can protect people from hepatitis B. We should protect them, and we need to be great advocates of the hepatitis B vaccine. The highest risk for HIV is with a hollow bore needle that's been in an artery, that's been filled with blood, large volume of blood, visibly bloody, and the source has a high viral load. It's actually not that easy. It's not impossible, but it's not that easy to contract HIV from a needle stick. Hepatitis C is about a 0.2% chance with similar type of needle stick. Okay, we talked about starting PEP as soon as possible, but not after 72 hours again, unless you get an ID consult. And the SHEA guidelines did update the medication recommendations. I hope if any of you are treating bloodborne pathogens exposures in your clinics, or you know of others that are, that they're all using the 2025 SHEA guidelines and the newer medication regime. The newest regime, and the one that we use, is bictegravir. It's BIC, FTC, TAF. It's a 3-drug regime. This is what CDC says now. It's a 3-drug regime and 1 pill. It's fabulous. It's well tolerated. It's once a day, so we get great compliance. And compared to, I don't know if any of you all are as old as I am, but we used to have the 3TC and the Combivir and the meds that people used to get very, very sick from. I would often have people come into the clinic within 2 or 3 days begging me to take them off of the medication because the nausea, vomiting, headaches were so bad. These medications, they're now tolerating very well. They get through the 28 days. We're going to have the full duration. We have to check for medication compliance. That's very important. And if you're prescribing this, the PEP medications, you must see them at 72 hours. And you're going to, at that 72-hour, do a brief physical exam focusing on abdominal, cardiac, respiratory areas that you could see side effects, and also the compliance and side effects. So if they're having side effects, if they have nausea, and these, sometimes people do get nausea or other side effects with this, they're manageable. I know none of us love to prescribe the antiemetics anymore because of the long QT issue, but we do have antiemetics that can be used if somebody has nausea, vomiting, in order to keep them on the drug. Now, there are certain situations where you should, OSHA says, CDC says, you should consult an ID specialist if somebody needs to be put on these medications. Again, it's not to delay. It's in general, for most of the population, not going to hurt them if you give them one dose while you're waiting to call the ID consult. If somebody's pregnant or breastfeeding, but remember, we give pregnant people the dictegravir and other HIV medications very successfully without harm to the fetus. So don't shy away from, in the past, we say if somebody's pregnant, we're not going to treat them, but that's not the case anymore. You should get an ID consult, but we're not going to shy away from that. If somebody has renal or hepatic disease, you may need to make a renal adjustment on the medication dose. If there's source resistance, so if you know the source, if you have the source in hand, you need to make sure that there isn't a history of resistance, especially to the medication regime you're going to put them on. Oftentimes, ID will do something different. They will match the meds the source is on and not give them the standard PEP protocol. So it's very important, if you know the source, to get as much information as you possibly can. One thing to remember is you need to educate the patients on the side effects and also when to take the medications. It's very important to have them take them away from the polyvalent cations, calcium, magnesium, iron. Make sure, because they will bind and they won't get the full effect of the medication. And again, managing nausea, diarrhea, and anxiety so that adherence stays high. All very important. Okay, let's talk about baseline testing. The source person, hopefully you have the source person in hand, and we're going to do HIV, antibody, antigen. We can do rapid, and the rapids are considered for initial testing, sensitive and specific enough to use as a result if it's negative. If it's positive, you have to send it off for confirmatory testing. Now, I didn't write this down, so I think everybody should be using this today, but it should be the 4th generation HIV 1-2 antigen antibody test. I don't know anybody that's not using that, but the 4th generation is the most sensitive and specific. If they have known HIV, they have a known history of HIV, we're going to do an HIV RNA with the viral load and get their therapy history, their medication history. We're also going to do HCV RNA. Now, we do an HCV with a reflex RNA only because it's a little bit less expensive. It gets the same outcome. But if you want a rapid result, if you're concerned about this particular patient, they might be an IV drug user, or they said they thought they had a history of Hep C or have a history of Hep C, then just do HCV RNA. Now, you're going to do the Hep B surface antigen only if the employee has not had their Hep B vaccines and a positive titer on file. We're going to talk a little bit more about that. For your exposed person, your healthcare worker, again, we're going to do the 4th generation HIV test, same Hep C antibody with reflex to RNA. And if it's positive, the RNA will be positive. Only do the Hep B. You don't waste the money anymore. If they have a positive titer on file, don't even bother to order the hepatitis B. If you're putting them on PEP medication, we do a CDC, hepatic labs, and if it's a person in childbearing age, we do a pregnancy test. And we do keep rapid pregnancy tests in-house. Okay, let's talk about hepatitis B documentation. Again, super, super important. They need to have a hepatitis B titer greater than 10, equal or greater than 10, to be considered immune. And I cannot tell you how many times I've gone into healthcare settings, I've been asked to consult in healthcare settings because they're just not up to speed on their hepatitis B program. This is one of the things that OSHA loves to come in and audit, by the way. They will ask to pull all of your hepatitis B declinations, vaccine records, and find out what percentage your people are vaccinated. So please, 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 it's an easy thing to do. You can have clinics. It's just such a simple thing to do. And remember, CDC says it's not, I've got a titer, but they don't have any written documentation. Or they say, I remember having it as a child, just do my titer. Many healthcare organizations make their own policies around this. And remember, CDC, it's a recommendation, it's not regulatory. But what they say is, if there isn't evidence of 3 written hepatitis B vaccines documented by a healthcare provider with the dates and it's appropriately spaced, you should restart the entire series and not just titer them. Now, we do have a situation where people might be non-responders, and this goes beyond this lecture about when to give HBIG, how much HBIG to give, do you give it once, twice, but know that there are true non-responders and that these people, we're not sure genetically that they do not respond after 2 full series appropriately spaced, and they don't have a positive titer. These are the folks that we need to think about getting HBIG to quickly if the source patient is known to be Hep B positive or the source patient is unknown. So the follow-up testing is also much smoother. It was in the past, I know when I had my very first exposure, I had to be tested out to a year. That was extremely stressful. Lifestyle modifications for a year. My family was worried for a year. It's an extremely stressful thing. We have now shortened that timeline because we have medications. We have much better testing. So with HIV, we retest at 4 to 6 weeks. And then again at 12 weeks. If they are negative at 12 weeks, we no longer have to test. Okay, hepatitis C. Unfortunately, we do not have any post-exposure prophylaxis yet for hepatitis C. And of course, you all know there's no vaccine. But we do have some wonderful medications that people contracted in the past. I had healthcare workers that would contract hepatitis C from an exposure. It was a very sad situation. There's nothing we could tell them. There's nothing we could do. But today, if we test them, and we're going to test them at 3 to 6 weeks, and then again at 4 to 6 months, and they become positive, we send them off to hepatology. And actually, hepatology tends to wait a little bit because there is a percentage of people that will clear hepatitis C, right? And for those that don't, we now have these amazing drugs to treat hepatitis C. Okay, risk communication is part, as I said, is part of the clinical intervention. As I mentioned in the beginning of the lecture, in my mind, as important as prescribing PEP. There is nothing more stressful than just being given a medication and being sent on your way. Please validate that they've done the right thing by coming to report. First of all, we want people to report. There's always been, especially in the OR, Kevin, you might be able to corroborate this, but people don't report. There's a lot of under-reporting that goes on. Oh, I get stuck 3 or 4 times a day. I'm not going to bother. I'm busy. Or it was just a little pinprick. Please validate that they did the right thing. Very, very important. Name the unknowns. It's important for them to know what is known, but it's also very important for them to know what isn't known. So first start with the knowns. Tell them what we know right now. If you know that the source patient reports no history, if you have the source patient's results, but tell them what isn't known. Tell them, oh, we're still waiting to track down the source patient or ask the source patient to come back to clinic to get tested. Give them a plan. Tell them what the next steps are. Giving people concrete information is extremely important, and it's great at relieving anxiety. They're not going to be completely alleviated, but it will definitely help. Okay, so I have a couple of cases. Here we have 2 janitors emptying a lab red bag trash container. They're cleaning after hours. One of them was stuck by a hollow bore needle that was in the trash. Unfortunately, this happens all the time. I just heard a situation about this the other day. Somebody found a needle in the trash and stuck themselves. But the second janitor went to help his friend and was searching for the object. And this is a real scenario. People will actually bring the object they stuck themselves with to occupational health. We tell them all the time, we cannot test the object. Please do not bring it. It's a risk for additional exposure. You know, again, people panic. People are very anxious about this, and they do this. So the second person who was searching for the object found it and unfortunately stuck himself. So they both came to occupational health within 15 minutes. So the questions we have, was this an exposure? And what other things do we need to consider in this situation? First of all, was it an exposure? Remember what we said, in order to have an exposure, you need 2 things. Was this an exposure? Stuck themselves with a hollow bore needle, red bag trash.
Well, okay, I'll say yes.
Yeah, you would be right. Everybody who said yes is correct. So it's not only an exposure, but it's a double exposure. So janitor number 1 stuck himself with the needle was in a trench, and they did use human blood in this lab. However, janitor number 2 stuck himself, so he was exposed to whoever that source patient was, but he was also exposed to his coworker because the coworker's blood was now on that object that he had stuck himself with. So this was actually a very complicated exposure in terms of consenting. And, obviously you're about to ask the exposed person to find out the HIV, Hep B, and Hep C status of his coworker. They both had to consent. So this became very, very complicated, took quite a bit of time. But yes, it was a true bloodborne pathogens exposure, and very important to check immunity on both people. Now, when we find something in the trash, things we can ask, although it's not always the clear answer: when was the last time this lab was used? Was it used an hour ago? So that needle could be very recently put in the trash. Has it not been used for a week? HIV is very fragile in the environment. It can actually last in a laboratory setting in perfect conditions up to 7 days. But really in the open environment, in the ambient airspace, it really only lasts minutes. Now, on the other hand, hepatitis B can last up to a week. Hepatitis C can last up to 30 days, which used to make me cringe when I was in the emergency department, seeing people, working on a wound, grabbing for extra dressing supplies, not changing their gloves. Their gloves are bloody. They open the cabinet, they touch the cabinet door, they reach into the box of sterile gauze, pull it out, and now they've contaminated everything they've touched. And Hep B and Hep C can persist in those environments, and you don't always see it. And those are the areas that people don't always clean. So we have to think about what the persistence of the particular viruses in the environment. So when you have a discussion, a risk communication in a situation like this, unknown source, we used to say, if it's an unknown source, it's been in the trash probably for a while, we're not going to treat. We've turned that corner a little bit, and this is one of those things where you might want to get, if you don't do a lot of bloodborne pathogen exposures, get some professional consultation either from ID, from the PEP hotline. We do now sometimes treat these. So every scenario is an individual one, and every scenario may have a different outcome, a different answer. Okay, next case. We were a pregnant worker, had a splash, nose, eyes, mouth, wasn't wearing the proper personal protective equipment, face shield, with arterial blood from a patient known to have HIV with an undetectable viral load. Reported the exposure very quickly. Key question here: because the source patient has an undetectable viral load, does that mean you don't need to do anything about this? The HIV viral load was 0, undetectable. Any thoughts?
I'd say you treat.
Yeah,
You're actually treating 2 patients.
You're correct, Matt. And again, this is one of those situations, up until the new SHADE guidelines came out last year, we weren't treating these. We were saying, undetectable viral load, it's negative, they can't transmit. But now we're rethinking that. So we are now actually treating, again, this should get a professional consultation with the ID, the PEP hotline, especially because of the pregnancy, because you're right, you're treating 2 people. You need to consider PEP in a situation like this, for sure, even with a negative viral load. So, and some of the questions you want to ask the person is, why are they HIV positive? Are they an IV drug user? If they're an IV drug user, how recently have they used? Because all of these can change the risk communication. But again, that's why it's important to get the experts involved from ID or the PEP hotline. Clinical takeaways real quick. Again, number 1, first of all, we have to have an exposure. There has to be fluid, contaminated fluid, and a portal of entry. HIV PEP is critically urgent within 2 hours, but no more than 72. Please make sure all your folks have their Hep B documentation and their titers on file before this happens. And please, if they have a Hep B titer that's positive on file, do not redraw them because of the amnestic response, which we can't get into tonight. They may be negative if you draw them again, and it doesn't mean they won't mount a response if they've had a prior positive response. Hep C follow-up matters. There's no PEP, but early RNA testing identifies treatable infection. We can refer people on. And risk communication. And again, send people to employee assistance, onto psychologists, if they're having anxiety, because this is a real mental health concern. We can't just treat the physical part of the patient. We have to treat the whole patient. And these are just some references. This is the Bloodborne Pathogens hotline, which very sadly, again, because of governmental issues that I won't get into, they used to be open 24 hours a day, 7 days a week, and would answer live. And now they are on an on-call basis, but they are amazing. They are based out of San Francisco General, and they know me by first name because as many of these as I've done, I do still need to call. Don't ever be afraid to call them. They will get back to you. And again, if you have to start PEP while you're waiting for them to call and they just say, no, don't worry, stop the PEP, that's fine. But these folks are amazing. CDC exposure guidance is all on the internet, and OSHA and the United States Public Health Service guidelines are also on the internet. So again, thank you all for being here tonight. Any additional questions?